and it will be moderated by Claude Le Pen. Gérard, thank you. We have a huge responsibility. Is this the final bouquet we have to have? This is the apotheosis of the entire conference, so I hope people are not expecting too much of us. Now, the idea when we ask this question of an efficient health system is to ask the question, what would be ideal if we had no constraints, if we could dream of the ideal health system? And that's the role of politics, is to inspire a vision. And what would be the system we could propose to the French? Would it be very different from our system? Would it be the same but just better? And on what should this health system be based? And what improvement levers should it integrate? I'm always struck by the contradiction between the catastrophic nature of these diagnoses, that people say we're going straight into the wall, we're digging a hole, we're jumping into it. And it seems to me that there are still a lot of solutions, but sometimes the laws are way too complex with hundreds of articles and very little scope. And we have a law on the financing of our state health insurance that seems to be just copying and pasting previous laws. Even Vals's new plan, I think, is not radically different. So there's a sort of a contradiction. We're managing something in the margin, and we still have the idea that we need to completely revolutionize it. So do you think the diagnosis is too pessimistic? Do we think we lack political courage, lack vision? This is what we'd like to try to explore with you here. And we'd like to determine, what does France expect from its healthcare system? Is France happier than it actually would like to admit? Or truly the financial crisis, the deficits, the inequalities, the excessive expenditures, the corporatist domination, and the impossibility of reforming, all of this leads to an equation that means we really need to completely start from scratch again and revolutionize the system. It's not easy to draw or design a new system. In the novel or the story by Saint-Exupéry, he says, draw me a sheep, and he can't succeed in drawing the sheep. And he finally says, well, your sheep is not satisfactory. So it's not always easy to draw a new system. So we have two eminent representatives of the public and private hospital systems, Christian Ledors, who represents Vitalia, and Pierre Domy, who's the director of university hospitals in France, and Jean-Louis Touraine, who is a member of parliament and now senator. Yesterday, unfortunately, Gérard Larcher can't be with us because there are elections. There were elections. He told us he wouldn't be able to come, but actually he was able to come. So congratulations for having been able to find the time despite your electoral circumstances. So let's start with the hospital. Christian, would you like to start? Well, actually, I would prefer to start with the criticism. How would you redesign the system if you could? Would the ideal... Do you think the public and private hospitals both have their role in the ideal system? Would you like to participate in a new system with a different variety of statuses, non-profit, public, private? Would you organize differently depending on the sector? Would you regulate differently depending on the sector? How should we have designed it, and what do you think we need to do to improve things? Well, I think we should already say that we've done quite a bit. We shouldn't be too pessimistic. This healthcare system that was founded in 1945 has major assets, and one of the fundamental strong points that I defend, I think we should not only reform it, but we really need to completely revise it. I don't think just another reform will be sufficient. we need to completely overhaul it. We've had so many reports and green papers, white papers, committees. I think we're no longer at a stage where we're just observing the problems. I think we all agree on the main issues and the condition of our healthcare system today, whether it's from the user standpoint, the financial, economic standpoint, or the professionals. I think we all agree. I think there are some slight disagreements if we start talking about what needs to be done. There will probably be diverging opinions because we have a history. That means we've introduced a lot of politics in our healthcare system, a lot of local priorities, challenges, societal challenges, and we probably didn't limit our healthcare system to what it should be, its main mission, which is to treat people properly and prevent disease and educate them in terms of the major therapies and have public health that would be improved. That's the main objective of a healthcare system. So I think we should focus on this. I would like to say that the difficulty we have is that we won't all agree on what we mean by efficiency. You use the word efficiency in your title of the roundtable, but maybe my colleague here will find that something is efficient, whereas I will feel that it's not efficient enough. So we already have a diverging view of what is efficient. Perhaps the university hospital director is not in agreement with me on the term efficiency. Yes, that's possible. For me, efficiency should be medical first and foremost. We should think about first medical efficiency. I always believe that if medical efficiency is present, then economic efficiency will follow. For me, the quality of a medical project and a medical organization and medical teams means that the structure is high performing. But then it has to be managed well. But managing a structure is not the most difficult task. So we need to agree on what we mean by efficiency. The second thing that will be a problem is to be efficient. We need efficient tools, efficient organizations, and efficient actors. The problem in France is that we have a general distrust of the word efficiency. People always ask me, why did you reorganize your group to be more efficient? Behind this word efficient, people ask, why does he want to be efficient? And then people always think of money, of course, behind this. People say, oh, if you want to be efficient, it's to make more money. No, you can be an entrepreneur and you want to be efficient, to have a beautiful company where your customers are happy and healthcare professionals working in it are happy and all the employees are happy. And if you have a good economic result, then that's so much the better. But we can have a broader vision than just economic efficiency, in my opinion. Now, this hospital system, or this healthcare system, I think it needs to be improved. And I think we are lucky enough to be in a country where the diversity, for me, is a wealth. We are in a European system where the private sector has the highest level of representatives in terms of activity and presence. I'm happy with that. I travel a lot. And this twofold system with a public hospital with main missions, including training and research, and then a private sector, that they both exist in parallel, offering healthcare. I think that's very satisfactory. I think we need to give more freedom to both the private and the public sectors. The public hospital system needs to be freed up. I'm for a regional approach, but for more independence of the regional agencies. They don't have enough independence with respect to the elected officials. I was very disappointed to see these persisting constraints on the decisions that needed to be taken in terms of public hospitals in the regions, and this is a huge issue. This regional agency needs to be free and independent from the national authority. And then we need to organize a healthcare offer that's graduated. The French want proximity and they want specialties. And we can only do this with graduated. We can have clusters of proximity, but then group together the specialties in networks. So the mission will take precedence over the status. I'm for partnerships. And we can't say someone is allowed to do this because they have a public status and another person can't do it because they have a private status. I think we should go beyond that. Okay, we'll come back to that. This leads right to the debate. What is efficiency for you? Do you think that public hospitals don't necessarily have to be efficient? And I've been attacked in conferences by hospital staff who said, we don't need to be efficient. That's not our problem. Economic efficiency shouldn't be our problem. More autonomy for the institution. And do you see a complementarity or a partnership? How could you organize these relationships on the regional level? Because I think you also support the idea of a stronger independence and regionalization of institutions. Yes, there are two prerequisites that will allow us to be not so distant from saving principles that we can find for our system. I think we have a very surrealistic debate. Design a new healthcare system as though we were in a losing situation. In my job, I receive a lot of foreign delegations, and I've traveled a lot. And actually, when our foreign contacts look at our healthcare system, they consider us as being very close to the Holy Grail, and this is the orientation that they think we should follow. So I think we need to be very measured in our assessment. So when the WHO classified health systems, we said we had the best hospital in France. It was the best in the world, and that was not at all the case. But it was a healthcare system, actually, not the hospital system, for two reasons. We are the only country that combines the freedom of choice of your treatment establishment and your doctor without any sanction concerning the cost of the service, nor your income.
Now, either you have freedom of choice, but it's better to have a credit card rather than a Vital card, which is the health insurance card, or you have no freedom of choice. Now, in a new healthcare system, I think this is a first pillar that needs to be durable. We mustn't come back over that. So, except that what we often say is that this alliance between expenditure and actors, and then there's the mechanism behind the system. So this brings us back to the question of freedom. Everything has been socialized. Is that not where we need to be looking at? There are no dynamics without any freedom. And the second pillar of our system that has to be made sustainable is the system whereby we have a competitive offer. This has been part of law for a while. There's no freedom of choice if you don't have any competition and a plural offer. And there's no service quality if there's no emulation between different operators who obey a competition law. These are the cardinal rules of our system. And for hospitals that are public hospitals, they have a role to play here as well. Now, opposing efficiency and a concept of a public hospital is like being a sophist. If some are condemned to succeed, if some are condemned to promote excellence, if some are condemned to be responsive, well, we're talking about public hospitals for one simple reason. Because unlike private establishments, they do not remunerate shareholders. They therefore have a lot more room for maneuver. And the shareholder who is not remunerated, in fact, basically the shareholder is the deficit, the general healthcare deficit. But anyway, since 1974 up until now, we've had this system, so for 40 years. So there's a very strong constraint weighing down on our shoulders. Hospitals do not represent all healthcare expenses. And of course, this is something that we saw in the previous debate. Frédéric gave us the figures. So this is just to say that when we are serving a general interest, when we are serving a public service mission, so an emergency ward, the administration of healthcare with the best possible quality, with the contribution of the social core through health insurance systems, when we have that responsibility, well, we have a duty to be efficient, to be productive, and to be excellent. And so public hospital people need to be high-performing and relevant. Now, this duty Does it involve the closing of establishments? Yes, of course, some establishments. Everybody is eligible if they are outside of the performance requirements of society. Today, we have a very frozen system. This is what Christian was saying, and I agree with him there. We all know that there is a healthcare offer that is not relevant. This is something that I have come across in the neighboring region. You know what I mean. This is something that has been in the press. And it's been in the press for 30 years now. For 30 years now, we still can't make sure that the central power delegates to local authorities because there are connections and disconnections. I think we've got a real problem that needs to be solved. And I'm sorry about this, Senator and Member of Parliament. It's up to politicians. We need to get out of our emotional state, move on to a rational approach. And when we have a clear approach and we explain things technically and in an accessible manner for laymen, while citizens take the right decisions when they vote. So I think we mustn't limit ourselves to these challenges. So I just I can't quite agree with what's been said. What's been said is not what is happening today in public hospitals today. Well, all public hospitals had to find a happy medium, had to find the right kind of balance. Now today, a good director of a hospital, and it's not easy to be a good director who takes time with their personnel, with the union representatives in order to come back to a point of balance, a point of equilibrium, they are not rewarded. So it's the bad director, hospital director, who is rewarded because they don't have any deficits. So I think we need to make people accountable. We need to make directors of different establishments accountable. A director who is not doing a good job must be gotten rid of. There needs to be sanctions as well. So we've got a real problem with that. So let's say a few words about that, and then we'll move on to something else. No, it is a fairly caricatural vision of things that you're painting. If I take the situation of general managements of university hospitals, who have a big sector of responsibility, let me just remind you that they can be eliminated on a day-to-day basis. So I think that has to be taken into account. The second thing, the hospital deficit. Well, we need to make an objective analysis of this. A large share of this deficit is linked to the fact that public hospitals have to pay for a certain number of activities. Jean-Pierre Dor said something earlier on. It's the only place in society where lights are on 24 hours a day. And now I don't want to be miserable about this, but when you question not just regional agencies, but when you question the people in charge, the answer is, well, you know, it was part of the rates. This was the rates that we budgeted for. So in France, there is a certain amount of anticipation in terms of things that will happen in 2 years' time. So we need to be rational. And I think we need to look at the reasons of hospital deficits. There is an offer. It has to be regulated, and we need to be courageous enough to restructure this offer. Now, Mr. Touraine, politicians, do they want to reform? Are they conservative? The hospitals that have to be closed, are they part of local heritage? Is there a kind of a double language and a double play involved? You're an elected official. What about the ideal system? What vision do you have as a doctor, professor, all of the positions that you have? What, tell us about the noble characteristics. Well, we'd all like to have an ideal system. not just politicians. You need to have a certain level of acceptability. An ideal system that is imposed against voters, against health professionals, is not going to be developed properly. Now, elected officials, but also health professionals, tend to add a certain number of nuances to the debate. There was a report produced by the WHO in 2003 about health in the world, and the title of the report was For a Better Performing Healthcare System. France was at the head of the developed countries. So in France, we could have quality care offered in a fairly equal manner. That's what it was said, the report. So in theory, based on equality, but as was stated yesterday, there is not as much equality as it imagines. Our system has virtues, it has qualities. So perhaps we don't want to eliminate everything, even if we want to design something different. Now, obviously, we don't want just to plaster over what already exists. We need to do things differently. We all know this. And in the WHO report, the thing that was underlined was not rationality. It was not knowing whether the money invested brought in the best kind of health. It was more a question of the freedom offered to practitioners and patients, their autonomy, whether that was respected or not. So a criterion-based classification was carried out. So they looked at liberties offered to patients and practitioners. So France was well listed for a combination of factors. So there was excellence. Yes, we are all aware that our system hasn't really been, was not thought through from the start. Things have been patched up. Opportunities have been seized to make little changes. So it wasn't thought as it is today. It wasn't thought through as it stands today. So there are a number of things that are beneficial in the system, but that's not the way it was necessarily designed from the start. So after the dictatorship in Spain, Spain adopted a system as well. But we have this system. So wanting to break it down, break it up completely, that's something that involves risk. So let's look at the most important points where we can make savings. Now, the first point that we need to think about is the fact that there's no unit of management. I'm not talking about the duality between private and public sectors that we all want to respect, but our system with its dual hierarchy is fairly costly. Two pilots, as you know, who don't have the same objectives, not strictly the same objectives anyway, with missions that are not defined. You've got the state and health insurance system. The first is in charge of hospitals, notably public hospitals. The second is in charge of general practice. It's a co-piloted system, and that system needs to be clarified. Otherwise, there are going to be problems. So would you be for a national health agency, kind of bringing together of bodies a little bit like we did at regional level? I don't know if we need to get rid of what already exists, but things need to be better coordinated. That things are repeated in a superfluous manner. There are decisions that are difficult. The health insurance system depends on directives given down by the government. They have to follow these. That's not very comfortable, given that that system was not involved in the drawing up of these requirements. Let's take the example of health data, and there are other examples. I think that this system needs to be thought through differently to be better. There's not one hierarchy. There's a trilogy. You've got all of the health professionals as well, the doctors, and then there's a fourth section, and that is the patient section. And fortunately, the law on what patients are entitled to represents something that's important. So let's talk about these four components then. Between them, there's no trust between them. Let's check the example of doctors, for example. You know that there's permanent suspicion on behalf of the state. This goes back to the creation of health officials. It's something that is in our collective memory. People are suspected. When something comes down from the state, there is suspicion. So it's between doctors and the health insurance funds? No, there is a different type of suspicion there, not quite as strong. So sometimes there is a certain amount of complicity as well. But there isn't total trust, that's for sure. So there are these different problems. Of course, we've got to use our imagination when we're trying to redesign the system. Nevertheless, we need to use our reason to think it through. But it can't just be rational. There's no example where reason alone governs the development of decisions in organizations. And this is something that we were reminded of earlier on in a humoristic way by Eric Orsona in his conclusion. So basically, he was referring to Erasmus. You can see the extent to which our organizations need to be based first and foremost on something that's rational, but there will always be something that is connected to emotions, to imagination, to madness maybe even, just like with Erasmus. But whatever the case, our system cannot just be a cold, rational system because people will not buy into it if that's the case. Let me just say a few words about some concrete things now. What would we do if we wanted to... Let's imagine that you're a member of the government. Let's imagine that then. And let's imagine that we can put forward amendments. So first of all, we need to think more about alternatives. We're already doing this. Alternatives in terms of the rates for different activities. Not for all activities, but some of the activities. Much of the expenditure is focused on chronic disease. So the healthcare path needs something different because payment based on acts is affected by inflation. That generates costs and it generates other problems. When we want to have a greater relevance, and there are many things that can be done, the High Authority for Health can contribute. So in 2012, there was a survey carried out on doctors, and it revealed, and doctors said this, that 30% of acts were not justified. So that generates a huge cost. And sometimes there were useless costs that were dangerous even. So we need to think these through, of course. Secondly, we've talked about piloting, but we're behind in France. Let me talk about prevention, public health, transparency, access to health, education, health education, access to data. All of these things go hand in hand. They need to be developed together if we want to have a regulation that is not just self-regulation, regulation from above, but also regulation that is self-regulation. So what is the best match between training and the distribution of professionals and needs? For the moment in the system, things are done at random. It's clear that this generates additional costs in certain areas and insufficient access to healthcare in other areas. So we don't want something that is overly directed, but something that is not that can be self-regulating as well. Total freedom. Well, our discussion today is about freedom. Guy Valencien chose the word well. Absolute freedom, we know very well, generates harmful effects. Obviously, we need freedom. We're all for that. But absolute freedom is to the detriment of equality. It's to the detriment of efficiency. Total freedom means that each person can decide on useless acts being carried out. And if we want to have a balanced system, like in our republic, If we'd forgotten about one of the elements of equality, fraternity, and liberty, well, we would not have a balanced republic. So liberty, freedom, has to be going hand in hand with efficiency, equality, investment costs, and results obtained. Okay, so let's follow your plan. Let's coordinate things better. Let's coordinate health insurance, modulate remuneration, have more of a mix of remuneration. So we haven't. So we've never really talked about the global budget. So modulate things, diversify things, introduce new concepts in terms of performance-based remuneration, improvements, little improvements here and there, and then develop prevention, health prevention, health education, and a fourth idea, adapt local needs to the regional plan with regional agencies managing availability information, managing things so that, you know, we don't have students skipping from one region to the next. I think that would be good with the new regional sizes that we're going to be seeing. So we're going to have one agency for 3 different regions in the future. So it's the size that is important as well. So I'd just like to say something in response to what's been said. There's a lot of confusion in terms of the idea of liberty or freedom. But what about general practices and their freedom? I don't consider that general practice is a liberal form of practice, a free form of practice. Is that something that guarantees the solvency of our clientele? We are socializing risk. 99.9% of the population using the healthcare system is covered by health insurance. That means that because we have to design a healthcare system, it would be healthy for health insurance to be in charge of risks relating to its profession, and the state define the policy and regulate using operators, so hospital operators of different statuses, who would be in charge of executing the policy in their specified area. And as for hospitals, public hospitals, well, I believe, like others, that the public status is a barrier. And a senator who was president of the Hospital Federation of France, in a study that really contributed to the definition of the new law on hospitals, health and territories. Well, in this definition, there was the idea of changing the status of public hospitals, moving it more towards something like the status for private establishments with a collective interest.
Well, quitting the trials and tribulations of the hospital practitioners, I think we should be fighting on an equal footing. We're on a football pitch. On the right, you have some playing rugby. On left, they're playing volleyball. And the referee is a handball referee. So that's the problem, really. But they've got the same, they're wearing the same T-shirts. And the referee isn't neutral either, in most cases. Well, I would like to have a neutral referee tomorrow morning. I'd go for it. If the doctors are solvent, they're not liberal doctors because they have the same problems as everybody else. We're regulated on price and volume, and I don't know any economic activity that's regulated on both at the same time. It's one or the other. We are regulated on the basis of both. Well, we all are. As far as liberal medicine is concerned, there's always been an agreement. The departments, the regions, and the health authorities signed agreements, and it's been extended, which is the counterpart of expenditure, of the extra expenditure. Gérard Larcher, the 4 avenues developed by Jean-Louis Touraine, do they suit you? Well, since we are being asked to make a drawing, I'm a vet, so I'm not going to tell you directly what I think. And I think it's probably going to take a certain time for me to cough it all up, so to speak. Leonardo da Vinci's practice, because I'm chairman of the Chateau of Chambord, I would prefer to have the 2-way staircase. The page is not white. We've just talked about liberal medicine, fortunately, because private and public hospitals, there are very often mutual associations or things that the different communes do. And we also have the 1958 law. Nobody said a word about that. And that has had a big impact on how hospitals were organized, even more than the agreement after the resistance. You've got the Breuer report, which covers less than 10 pages. It's a report that sets out a few orientations in a specific way that I've always considered as being useful for the private sector, the public sector, and the liberal sector. In a country with a Marxist past like France, I'm not quite sure that we've really emphasized quality enough. And I think that we need a stimulus. By ethics and quality, the public has actually indirectly regulated the private system. And I think we've now got a system that's going quite well. It's been working for the last 55 years or so, but today it's got to rise to the challenge of the coming 50 years. And I think that's our next assignment. Because whatever the side you're on, whether you're deputy or senator, let me advertise a bit for my own job. Things are difficult because you can't talk about public deficit in the territorial collectivities. Where can you find 10 billion to start with? At the same time, there's the challenge of the aging population and progress. Progress costs even more than the aging population. And in the 45 coming years, you're going to have a growth of more than 80% of the population over 60. And diabetic bodies are something that belong to my generation. So the third thing is that we are demanding more and more quality in our healthcare. It's a natural demand, of course, but we haven't got any true management at the present time. The hospital director in Rambouillet can't even manage the main items of expenditure. When decisions are sent into you, have to carry them out. And you've also got the collective bargaining system, which is something that was signed in another era. And I don't think the public hospitals have yet got over that. I can tell you that today we just can't manage if we don't think of another approach on that subject. So the difficulties are what? Well, the main difficulty is that beside an excellent article concerning myself in Aujourd'hui en France, you can read a poll. And the first vice president did a study showing that the French population is prepared for reform if it judges it necessary. So we're going to have the political courage to do this. We're going to have to say to ourselves, go on, ladies and gentlemen, we're going to have to go for it, including when this is very unpopular, because it's all too easy to say that this is all, it's the local authorities that never make any decision. French temptation. You know that in Siena there's a painting that is called Good and Evil. I'm going to talk about evil. Good and evil is the temptation, which is a permanent threat. In the face of difficulty, we've got to refocus. We're going to want to sign agreements and protocols, and things are going to become more and more decided on the ministry level. And this isn't going to be something that's going to enable us to anticipate costs at thousands of kilometers away from port. And just think of Concordia. We're going to have to do something different there. Reforms have to be made on pay. And in the Pital law, I don't think we went far enough in terms of territoriality. There's nothing concerning health in the territorial reform, and it's probably one of the major subjects, one of the major topics. Then you've got the issue of flexibility and cooperation. And I think that we're going to have to come back to a statutory idea, which is even older, because it was originally born under the French state. It seems to me that we're going to have to review this idea. And here I'm talking to my colleague opposite, who's a deputy. We all know that we've got to control expenditure, but take care. We don't want to take the easiest way. We've been hearing about ambulatory surgery, but I don't know how to convert our hospitals in this respect without some investment. So the investment has to be the counterpart. It has to be the counterpart of this type of regulation, which has to be done locally and not centrally. Having read this report, I can tell you we don't need 99 other reports on the subject, but in the future, there's a draft law that is a sort of protocol of trust between the director and CMU, and I don't think this is really going to make people get on a better. I think we've got to invent the hospital differently and imagine that the public sector and the private sector are not two opponents, and the respect of cooperation is a very important one, that a territorial approach is another way of providing an answer, but we're only going to succeed if we do it with the health professionals out there. That's essential. It was a bit too long, Mr. Le Pen, I'm afraid. You asked me to draw a system, and I came up with good and evil. What about the statutory reforms? Do we have to review that? Do we have to unify the personnel, the administrative, the medical professions, and so on? Because that's going to be something revolutionary. Well, I was shown three proposals. The first was to convert the status of the public hospitals so that they were able to have the same status as the private ones, non-profit private establishments, which meant that this would be a gradual process. And secondly, we also proposed to create doctors on a statutory basis, because it's very important to consider that these are full-time jobs. But for the same status and under the same aegis, we could find other responses. I'm president of the Commission of Public Services, and the telecom item has changed radically over the last few years. But with a state commitment, and the state has to keep to its word, why not change things in the hospitals too? These are pathways to explore. And if we don't have the courage to do these reforms, do something with the deficit, population is increasing, and we're going to have even more deficit, and that means losing competitiveness even more. What I wanted to say to Mr. Larcher, it's wonderful. The problem is that today we've got a Minister of Health who seems very courageous in making new laws, but the law is exactly the opposite of what you've just said. It's a law that centralizes everything, that gives more power to the state. It's a law that is going to get everybody's hackles up in the public and the private sector. It's already happened in the liberal sector, and it's going to happen very soon also in the public hospitals. The concept of partnership is totally dismantled, because the theory today is it's better to have two hospitals 80 kilometers away from each other in partnership than having a hospital in a partnership with the clinic next door. And I can't see how we're going to be able to organize a network, a mesh all over France when status is more important than the actual assignment. We're all guaranteed to have specifications for quality for a long period, because I know that you sat on a commission concerning the private establishment, and we've put a lot of investment into them. But what I'm really concerned about in this new draft law, because what we're being asked to do is draw a picture, but the Minister of Health is drawing the opposite picture. Well, on the draft health law, Mrs. Touraine is telling us that it's not a draft law for the hospitals. It's for the hospital personnel, but as everything that's in the law concerns the hospital directly. And whether you want it to or not, the hospitals are defending their own interests, and they're at the core of the system. When I say hospitals, I'm talking in the generic sense of the term. I'm not distinguishing one for another. Now, just a minute. In the law, what are the provisions in the 50 articles? Well, we actually chaired for the public hospitals and brought out a report that we handed in a few months ago to the minister on how the hospital clusters were managed, and we recommended, above all, to put nothing in the law concerning governance, because we cram in all the different reforms, and we haven't even digested the previous one when another one comes along. And I must say that, as Gérard Larcher said earlier, the idea of a contract for governance between the head of the hospital and the president of the medical commission seems to us to be something that's going to induce counter-performance in the elementary management of a company that provides public service. And if we need to innovate in the hospitals, it's to give it more autonomy than it has today. It has autonomy on paper, but we need to create all the conditions we can so that there's a sort of entrepreneurial spirit in the management of the hospital and the heads of each of the units. That's how we're going to be able to care for the patients better, because we'll be able to optimize the means, take the right decisions at the right time, using the right means for the patients according to the protocol of care. We need the least laws, decrees, and decisions possible. Well, what scares everybody is that we've got a sort of demographic window in the coming years that's going to be difficult. We're generations that are going to leave their jobs because we'll be of retirement age, and we don't seize this opportunity to guarantee that the situation is going to last and create contracts, that's to say more mobility and flexibility in managing our hospitals. In my opinion, I think we'll have missed an opportunity. Jean-Louis, I agree with what he's just said. I think most of the professionals don't really want any major upheaval. They don't want the rules to change. Okay, so perhaps some change is a good idea because we've shown that there are defects. But I think that we've got to leave a certain capacity to the people in charge to manage, improving their management conditions, perhaps. But I don't think we want directives and standards and extra work and upheavals to come along and hinder the process, because it's going to destabilize the personnel and the balance there is between the hospital director and the union leaders. And I think it's in that way, with that spirit in mind, that the future law is going to work. I don't think we should be accusatory. This is only a draft law for the moment. And could be used as a common denominator, but the minister is very keen on this law, it said. Well, the same minister is saying that she's expecting a lot of Parliament to amend and perfect the law and amplify it, which is just not possible because the law is very long. There are 5 headings and a large number of articles under each. So let's seize the opportunities and try and go for it. But on a philosophical level, we're all very ambiguous. Let's accept that fact. We are looking after our own affairs, but we're asking her at the same time to regulate some things. We want you've got the 2 extremes that nobody wants here. We're all in a certain environment, but nobody knows where the middle is. And all we really need to do is to just move the button a little bit. But are we in a system that could be better administrated? Well, no, because we're talking about Sovietization, and even in Eastern Europe, they're administered better than we are. The French people don't want that sort of system, and or on the contrary, could be a system in which we'd increase the role of regulation, but by the market, by direct market law, competition, and then in that case, other people would be against it. But some would also be against the trend to inefficiency and the risk of wastage or inequality. So that wouldn't be accepted either. So whatever happens, you've got to be between the 2. And you can move the button one way or other, but the goal is to not have a law. Be careful, because this law hasn't been voted, and we can certainly influence it. I've made contacts with the ministry and also with her cabinet. And I think we need to maintain the proper balance and not favorize some rather than others. Okay?
Well, that's good news that the minister is very open-minded. So we have 3 minutes left, 1 minute each. I'd like to give the example of a false good idea. We keep on talking about ambulatory surgeries, outpatient surgery. People keep saying that other countries are about 60 to 70% of outpatient surgery, and we're not at those rates. Let's meet 3 years from now, and people say that this will help. These outpatient surgeries will save money, and I will bet that they will actually waste money. You can only do this if at the same time you restructure your public hospital and you close certain wards and structures. And yet this will not be done. It will not be done. I can be sure that it will not be done. So the unbelievable calculations of billions of euros that will be saved is completely unrealistic, I think, without patient surgery. Well, the healthcare system that I would like to design, I told you the two columns of the temple, the two pillars, both the freedom of choice and the socialization of risk. This is a change in status for the hospital to give it more mobility and its capacity to restructure itself. Restructuring is underway in a very strong fashion, and I can testify to this, that this restructuring in an initial phase destroys jobs, and so we have to anticipate this, these jobs that will be eliminated, and that comes back to innovation. And if I could stop with a formula and conclude with a formula, I would say that I would like a hospital with less civil servants and more missionaries. Not bad at all. We'll put that in the book of quotes from Shem 14. I'd just like to say two things. I believe that the state should be present in the strategic functions. It's the authority of the state. And for a certain number of major objectives, that's where we can say liberty, equality, fraternity. These are Republican values, values of our republic. But beware of these quick fixes that are in fashion. When I was the mayor of Rambouillet, I started focusing on the hospital. There was a gentleman, Pierre Reynaud, who was my vice president, and he made me love the hospital. I knew nothing about hospitals. And at the time, people said the overall budget will save us. Tarification, unit tarification will save us. And people said outpatient surgery is a bad idea. So I think the territorial aspect, I think we have to stop centralizing all of the decisions. I took a nautical comparison earlier. I think we need to deploy ourselves all over the territory and never forget that our objective is to treat men and women, care for men and women. And that is the level that really sets a level of democracy, is the level that brings us all together with our diversity. Yes, yes, we'll vote for you. Well, this roundtable, which was supposed to be private-public, left-right, has finished in a unanimous conclusion that we need to change the system, we need to reform the public hospital. We're in favor of reform, but revolutionary reform. So, thank you all. Thank you. Thank you. Sham 2014 is finished. Thank you to all of the partners who helped us and supported us to organize this conference where we launch these ideas. And next year, it will be the 25th and the 26th of September.